treated thousands of patients for skin cancer. Despite having multiple skin cancers, they still don't practice sun-safe behaviors. That's really frustrating. All you need is like 10 minutes of sun to get the recommended vitamin D for the day.
Dr. Adam Nabatian is a double board-certified dermatologist and Mohs micrographic surgeon by the American Board of Dermatology. He's an assistant clinical professor at Mount Sinai Hospital and recently opened up his own private practice here in New York City. This episode is sponsored by Feel Confident. For the best in-class skincare and hair care, check out feelconfident.com. All right, so when it comes to hair and like all the hair work that I do, sometimes people don't know like some of the basics, so they'll ask me things like, well, can I do a hair transplant from like someone else's head, for example? And I'm like, no, I can't do that. And I try to bring that up in certain videos and just certain information that we put out there. But there's just like certain basics that I just like wish people knew, and there's a lot of misconceptions about some of the medical therapy for hair. So when you think about skin, like what are some of those things where it's like, well, these are just some of the basics that you sort of hope that most people know, but that you find that a lot of people just don't know?
Well, I wish that people would realize that the importance of starting to take care of their skin at a young age. So a lot of the patients that I see, when they were younger, or I see teenagers, I see people in their 20s, 30s, 40s, 50s, 60s, some people that are over 100, and some people, they don't realize how the importance of starting to take care of your skin at a young age. Like patients don't wear sunscreen, patients don't practice sun-safe behaviors, some patients use tanning beds still, even though tanning beds, are known to cause skin cancers like melanoma. It's really important to start taking care of your skin at a young age. What you do as a child, what you do as a teenager, as a young adult, really matters. So, I definitely recommend, practicing sun-safe behaviors at a young age, whether it's wearing sunscreen, reapplying it every couple hours or sooner if you're active, or, not using tanning beds. These are super important. If growing up, if you grow up like in Florida or even in New York and you have a lot of severe sunburns, you're at higher risk for getting skin cancer when you're older, as an example. But another thing that I frequently see in my practice are patients coming in with like a bag of 20 skincare products. So recently, like a lot of patients, they follow certain influencers on social media like Instagram, and they literally bring in a Whole Foods shopping bag filled with like different moisturizers, like 5 different cleansers, 3 or 4 sunscreens, toners, and like these patients are coming to me and, for the most part, they're really unhappy, but since their skin is actually worse than what it was. Mm-hmm. So I try to tell patients the importance of keeping it simple. It's not, you don't want to do, keep it simple. Simple is best. Use a cleanser, a sunscreen, definitely moisturize your skin. Those are the basics of any good skincare regimen. And we always add things to different problems patients have. Like if they have acne, we can add an acne cleanser. We can add over-the-counter acne medications, prescription topical medications, or, medications by mouth. For other patients, we can add certain things like vitamin C serums. We could add retinols to help stimulate collagen or help exfoliate their skin. But, try to keep it simple. And I wouldn't, try to, do everything that you hear on social media. So keep it simple.
Yeah. On the prevention side, especially with sunscreen, like how early should one start? Like, should parents be applying this stuff on their like little babies? Like, I mean, how early should the sunscreen application start?
So it should really start. I mean, if you have like a newborn, I would definitely try to keep them away from out of the sun as much as possible. I mean, obviously you're going to go out, you're going to get sun, but, wear sun protective clothing, wear like a sun hat. The areas that are exposed on the sunscreen bottle, I think it says 6 months. So patients should be 6 months or older. But I have a 1-year-old, I have a 2-year-old. We were applying sunscreen on them prior to them being 6 months. We would always use something that was a sunblock. It had titanium or zinc, since your body doesn't absorb these. But the main important thing is just for a baby, you should definitely wear sun protective clothing. Like anywhere that's exposed to the sun, that's where I would put like a sunblock, something with zinc or titanium. But I would definitely also, consult with the pediatrician, but usually it's fine. That's what I would recommend.
And on the topic of like all these over-the-counter products, it feels like almost that people are like like diagnosing and self-treating quite a bit when it comes to their skin and just dermatology. And like, you go to like a Sephora and they just, the person who's there, the consultant, whoever the salesperson is, right? They sort of ask you like, oh, what kind of skin type do you have? And do you have any of these problems? And then on the bottles, they'll say like, oh, for acne, use this. And so do you feel like they should be seeing like a professional, a physician, much earlier in the course, and like maybe just start with those basic things that you talked about, like the cleanser, the sunscreen, moisturizer, and then like anything extra, maybe get some professional advice on? Or
I would definitely recommend that, patients or parents bring their teenagers or kids into the dermatology office so that we can start a skincare regimen at a young age, like basic cleansers. There's so many cleansers out there. There's exfoliating cleansers, there's cleansers for oily skin, for dry skin. So it's really important to see a professional. I mean, there's nothing wrong with the person at the counter at Sephora, but, I would definitely recommend coming in and, seeing a board certified dermatologist or like a dermatology provider that can really that knows your skin best, that can examine you.
And I guess some of this was already covered in a way, but any like pet peeves as a dermatologist, the things you see that you're just like, ooh, like this is no good?
So I'm a dermatologist, but I'm also a Mohs micrographic surgeon. So I treat a lot of skin cancer. So I've treated thousands of patients for skin cancer in the past few years alone. And some patients, despite having multiple skin cancers, they still don't practice unsafe behaviors. So I try to instill in them, wearing sunscreen, reapplying it every couple hours or sooner if they're like active and sweating, or if they go swimming, or just wearing sun protective clothing. But some patients are just really stubborn, and they still,
even after they've been diagnosed with the skin cancer,
even after doing multiple skin cancer surgeries, they're still they still don't practice unsafe behaviors. That's really frustrating.
I wonder if people feel that maybe it's like too late, like they've already formed cancer, so then it's like, what's the point?
So some of the patients tell me that, but I always tell them, listen, it's not too late. You can still, minimize, you can still help limit the ultraviolet radiation you're getting now from the sun. And by doing so, you're decreasing further skin damage and damage to your DNA, which leads to skin cancer. So it's not too late. I mean, the past is the past. If you've had multiple skin cancers, the sun is taking a toll on your skin, but there's still opportunities to wear sunscreen and help limit, the ultraviolet radiation that's damaging our skin.
Yeah, I mean, it sounds akin to like cigarette smoke, I mean, of course, if you start that at an early age, I mean, there are the toxins and the changes of your genetics that occur, over time, and that can be damaging. But, you can always like stop the cigarette smoking, and then, try to protect yourself for at least, years to come, from the time that you've stopped. So it's helpful to stop at a certain point. So it's kind of like it's helpful with sun protection to like actually do something preventative, even if you've had some damage from your exposure before.
I'm not telling patients to lock themselves up in their house and like don't get any sun. We're just I like the sun. I love to, and my favorite season is the summertime. I like to go out for runs. I like to play sports, go to the park with my family, go to the beach. Just wear sun protective clothing, wear sunscreen on the exposed areas, reapply it. By all means, go outside, enjoy the weather, do what you got to do, but just practice unsafe behaviors. You don't have to lock yourself up in your basement.
Right. Some people say that, well, what about like vitamin D levels? Like, don't you want some sun because your vitamin D is going to drop
So you're still going to get vitamin D from the sun if you're wearing sunscreen. We're not putting on the, appropriate amount where you're not reapplying it as frequently as you should. You could also recommend patients take vitamin D supplements. So a lot of patients need vitamin D supplementation for many different medical conditions, but I would definitely you're still going to get vitamin D. So whether you wear if you're wearing sunscreen, you're still going to get vitamin D. All you need is like 10 minutes of sun to get the recommended vitamin D for the day.
Got it. And then to drill into like specific sunscreens and like SPFs, if you can just give the overview. I know there's like organic, inorganic sunscreens. So like if you could just kind of talk through that a little bit, and also just your preference on if you have some favorite ones. And then the whole idea of like SPF, like what even is that? And is there like a certain number that people should be looking for?
Yeah, so the best sunscreen is the sunscreen that you're going to wear. So I could recommend a specific sunscreen, but if you're unable to get it, or you just don't like the way it feels, then it doesn't matter. So, what I recommend to patients is to wear a sunblock that has SPF 30 or higher. It should be broad spectrum. That means it covers against UVA and UVB rays. I definitely recommend reapplying it though every couple hours. That's the key word that you hear me saying a lot, is the reapplication. So a lot of patients will get, I'll get an SPF 100, but they don't reapply it. They put it on once in the morning before they leave for the day, and the sunscreen's going to evaporate, or you're going to sweat and it's going to wash off. So the key is reapplying it every 2 hours. So as long as you're wearing SPF 30 or higher, I would definitely recommend reapplying it every couple hours. And again, sooner if you're like playing tennis and you're sweating, or you go swimming. And I really recommend mineral-based sunscreens. Those are sunscreens with zinc or titanium. It's called a sunblock because it actually blocks the ultraviolet radiation, as opposed to a sunscreen that absorbs the radiation. So definitely, I would personally, again, SPF 30 or higher, and a mineral sunscreen that has zinc or titanium.
Straight to the point. So let's talk about now skin cancer. So someone, let's say, who is not practicing good sun-safe behaviors, and that eventually ends up getting, well, let's just go through this then. Like, is every skin cancer because of the sun, or are there other causes? And is sun exposure like the primary cause of skin cancer?
So ultraviolet radiation is definitely the primary cause of skin cancer, but whether it's ultraviolet radiation from the sun or ultraviolet radiation from a tanning bed. So, patients still use tanning beds today. It's a little less common than it was because it's been, there's certain laws now passed in certain states. Like in New York, you have to be 18 or older to go to a tanning salon. But using tanning beds, the ultraviolet radiation caused they found about a 75% increase in the risk of melanoma. Ultraviolet radiation from the sun, that's the main, environmental factor that causes skin cancer, just because of the damage it does to our DNA over time. Patients that are more fair skin like yourself, patients that have light eyes, light hair, they're definitely more genetically susceptible to it. But I've seen patients that are African Americans that have had skin cancer. And, usually those patients come in to see a dermatologist later on in life, and the skin cancers have been present for a while longer. So it was been detected later on. And for those patients, there's a higher mortality or morbidity rate.
What are some of the other causes of skin cancers other than like UV?
So a lot of patients back in the day used to get skin cancer from exposure to certain chemicals like arsenic. I remember when I was I've never seen it, but I remember when I was a resident, I believe patients that would clean people that worked like to clean the soot in chimneys. They would go into the chimneys and clean all the soot in there. They were at higher risk. The predominant skin cancer I see nowadays is from ultraviolet radiation, but there are patients that have other cancers like solid organ cancers, patients that have had transplants like a heart transplant, a kidney transplant, and are on immunosuppressive medications. So these patients are on medications that suppress their immune system. And by doing so, the immune system doesn't just fight infections, it also helps fight cancer. So by suppressing your immune system, these patients are at higher risk for skin cancers. I've seen patients that have had transplants, like I said, like a kidney transplant, who have had 10, 20, 30 skin cancers. So definitely like immunosuppressive medications, or patients that are immunosuppressed at a much higher risk. I know you're very fair skin yourself and your
Yeah.
do you have any family history of any skin cancer?
No, we don't. For skin cancer, we don't fortunately have any family histories. Some like lung cancer my grandfather had, but that was from his smoking. Yeah, no, cancer fortunately isn't a big thing in the family. And yeah, no one's had a skin cancer actually. Yeah, come to think of it. Yeah, my aunt on like my uncle's wife, you know, it's like
Yeah.
not a blood relative, but she's had her share of skin cancers. Had Mohs at Sinai actually
Okay.
a few times, but again, not like a blood relative. Yeah.
I mean, skin cancer is the most common cancer in the world, so usually, if you personally haven't been affected, you'll know someone that has been.
I wanted to get back into the tanning bed discussion, and like, are they all like kind of created equal with like similar amounts of like UV radiation, or are some like much lower exposures and still could be safe, or just they're all like all terrible?
I think they're all terrible. I
Yeah.
would never recommend someone go to a tanning salon and use a tanning bed just because your risk of skin cancer is significantly higher. So, if you wanted to get a tan, go get a spray tan. There's so many places now that have like spray tans.
And that's safe.
Yeah, that's definitely a lot more safe. I would definitely recommend a spray tan. There's no such thing as, like going to a tanning salon and getting like a good like base tan, or going to the beach and getting some sort of like base tan. You're increasing your risk of skin cancer, you're causing sun damage to your skin, you're giving yourself like premature aging with wrinkles, brown spots, sunspots, you're destroying the texture of your skin, and most importantly, you're increasing your risk of skin cancer significantly.
Yeah, it's crazy to me that like it's still completely legal to have like a tanning salon if we know the damage that it causes. But I guess, you know, similar to that again with cigarettes, it's like the stuff still is out
It's
there.
still
People
out
can
there.
still
People
buy
are,
it.
yeah.
We know the damage it does, but I guess, you know, people make their own
All we
decisions.
can do is, educate patients and, just get the information out.
So let's get into like how to detect skin cancer and the surveillance that I guess people should maybe just be doing at home. Versus also like once they maybe spot something and come to you, kind of like walk us through that.
Yeah, so I definitely recommend that everybody see a dermatologist once a year for a skin check. It's part of your like preventative health. A dermatologist would look at your skin from head to toe. They would look at all your moles. If patients have been found to have a skin cancer, it's recommended that they get a skin check more frequently. But patients should also do just screening for themselves at home. They should look at themselves in the mirror, look at your face, look at your body, use a mirror, look at your back in the mirror, or have like your spouse or a loved one look at your back or the areas that you can't see. Because, it could really save your life. There could be something there that you didn't notice, that you can't see, and by the skin cancer has a very high cure rate, but it's if you're able to catch something early, it's something that could be cured, as an outpatient procedure in our offices. So it's incredibly important to just, look at our skin, see a dermatologist once a year, for a skin check. When we look at you, we just use our eyes. We have a handheld device called a dermatoscope that looks at each mole. It's basically like a type of magnifying glass. But we also rely on patients. So patients frequently come in to see me. Oh, I have this mole on my abdomen that's changing. Oh, this bump popped up on my nose and it's been there for a few months. It's not going away. It's starting to bleed. These are things that, we definitely look for when a patient comes in to see us. But you have to come in. Don't blow it off. If it's not going away, definitely come in and see a board certified dermatologist.
I remember in medical school we learned about those like ABCDs of like
Right.
moles and how they change, but maybe just give people like an
Yeah,
idea of
so
that.
there's a good mnemonic out there. We call it the ABCDEs of skin cancer. So A is asymmetry. So one side of a mole should be the same side as the other. They should be like mirror images. B is for border. So the border should be nice and smooth, nice and regular. It shouldn't be like jagged or shouldn't be scalloped. C is color. We would like the mole to be a nice uniform color. It shouldn't be like black, brown, red. It should be a nice uniform color. D is diameter. So we like the mole to be, this about the size of a pencil eraser or smaller, but there's some moles that are larger than that, and they're totally fine. It kind of all depends on the context about these other factors. E is evolution. How did the mole change with time? Did it all of a sudden grow rapidly? Did it start to bleed? Is it itchy? Has it grown slowly over time? These are important questions that we ask. So, the ABCDEs is a good mnemonic of for skin cancer.
Yeah, and so like let's say someone detects a change and they come to your office and you confirm that it does look suspicious. What do you do with that? I mean, I kind of know the initial answer to it, but just if you can explain to people, like, is there like more imaging involved sometimes? Do you just jump to biopsy?
So if a patient comes to us, we examine them, and I use my dermatoscope, my handheld magnifying glass, and the lesion does look concerning. Then that we would discuss that with the patient, and I would recommend doing a biopsy. So biopsy, we just give the patient a local anesthetic, and then we just shave a part of the lesion, and then we send it to a lab, and a few days later, we're able to get the results from the dermatopathologist. So we send it out to the pathologist, who looks under the microscope and tells us what they have, whether it's a normal mole or like a normal benign growth, or if it's a skin cancer. And then at that point, we could have a conversation with the patient. We can, go over treatment options, if treatment's even necessary, if it is a skin cancer. But, if it's totally benign and fine, then, we just monitor you and, recommend the regular skin cancer screenings.
Do you have patients where you detect that something looks suspicious, there's a lesion there, it's been changing, it's been bleeding, and you recommend a biopsy and they just don't want it?
Of course, yeah. I mean, I practice mainly in New York City, and we have a lot of patients that, are on the go all the time. They're constantly traveling for work. They're constantly going international, and most patients, adhere to my recommendation to get the biopsy done. But there are some patients that, you know, the life circumstances they have at that time, whether they're very busy with work, or they have like a big presentation coming up, they're have a wedding coming up, they don't allow me to do biopsy them at that time. But for these patients, I kind of just go over why I'm recommending the biopsy. This is a suspicious lesion. It could be a skin cancer. If it is a skin cancer, we want to confirm that, and we want to treat it early. The skin cancer, like I said, is usually highly curable as long as it's detected and treated early. So it doesn't, if we treat something early, you're most likely going to be cured, and you won't have to worry about the cancer spreading or getting like any sort of disfiguring scar.
Right, because over time it might just grow, and then the
Over time,
treatment's
the
gonna be
skin cancer,
problematic.
right? So some skin cancers are slow growing, but there's other skin cancers that could grow rapidly and could be lethal or deadly very quickly. So we don't always know. We never know the progression of a skin cancer. We have to first get the diagnosis down.
So right, so let's say you sent it out to a lab and they come back with the diagnosis. How do you decide how to like fully treat them of that mole, whether to remove
Sure.
it? You have different
So
ways of removing it.
the treatment is based on the diagnosis and the depth of the skin cancer. So let's say someone comes in with a basal cell. A basal cell is a slow growing cancer. It's actually the most common cancer in the world, not just the most common type of skin cancer. But if the basal cell is superficial, if it's just on the surface of the skin, then we could, we have different treatment options that locally destroy the skin cancer, whether it's an ED&C or electrodesiccation and curettage. It's where we can burn and scrape the skin cancer, or we could freeze it with a cold spray like liquid nitrogen. We can use a laser. So there's certain lasers that, ablate the skin and vaporize the skin cancer to eliminate it if it's superficial. There's creams that we could put on, like chemotherapy creams. There's something called photodynamic therapy, where we apply a photosensitizing agent to the skin cancer. We let that cream, incubate on the cancer for a couple hours, and then we shine a specific light on it to help kill the cancer. Those are all options for superficial, like basal cells or squamous cell carcinomas or squamous cell carcinoma in situ. But the problem with those treatment options is that there's no pathological We're not getting a pathological confirmation that the skin cancer is cleared. So those treatments do have higher cure rates, but there are we're able to give patients higher cure rates with like surgical modalities, like a surgical excision where we, numb the area, we cut it out with a margin of skin and give them stitches and send out the tissue to a pathologist to confirm that it was all removed. There's also something called Mohs micrographic surgery, which is the gold standard to remove skin cancers. It's a tissue-sparing surgery where we remove the cancer and we try to preserve as much normal skin as possible. So we take the smallest of margins to get around the skin cancer and make sure it's clear. The cure rate is over 99%. Well, up to 99%, depending on the skin cancer, and it's predominantly used for basal cell carcinoma and squamous cell carcinoma, which are the two most common types of skin cancer. Mm-hmm. Those are the major treatment options. There's also radiation. Some patients aren't surgical candidates, or some patients just don't want to have surgery, or patients have had radiation for other types of cancers, and they're comfortable with their radiation oncologist, and they just want to get radiation. So that's definitely another option. It's not something that I frequently recommend, but it's definitely another, treatment option.
And the Mohs, is that something that most dermatologists offer, or just a select percentage of dermatologists?
Mohs micrographic surgery is a subspecialty of dermatology. So, not all Mohs micrographic surgeons, but, a good number of them are fellowship trained. Like I did a fellowship for Mohs micrographic surgery at Mount Sinai in New York City. And there I was taught the technique. I did a procedural dermatology fellowship, and a great focus of my time was to learn how to do Mohs micrographic surgery and to, perfect it. So most dermatologists don't do Mohs surgery. A lot of dermatologists refer the skin cancers, not all skin cancers, but skin cancers in select areas, like skin cancers on the tip of your nose, skin cancers on your head and neck, on your hands, on your genitalia. They might refer these more high-risk skin cancers to a Mohs micrographic surgeon to perform Mohs on, just to give the patient the highest cure rate, the smallest scar, and just like the best overall outcome.
Right. So when you're doing the Mohs procedure, are you looking at the tissue under the microscope yourself, or are you still working with a dermatopathologist during those procedures?
So for Mohs micrographic surgery, the Mohs surgeon is the surgeon removing the cancer. They're the pathologist. They're looking under the microscope to make sure all the margins are clear and that the cancer has been removed. And also they're the reconstructive surgeon. So usually a Mohs surgeon is doing all three. I mean, for a true Mohs surgeon, they are doing all three. They're removing the cancer, they are making sure it's all clear under the microscope, and then they're able to suture the patient to redo the reconstruction. Sometimes we do linear repairs, we do flaps, we do skin grafts. Sometimes we do refer the patient out to like a plastic surgeon or a facial plastic surgeon, an oculoplastic surgeon. Maybe the cancer's a large portion of the eyelid was removed, and we want to send that patient to, an oculoplastic surgeon just to, give them the best results, the best outcome. Sometimes patients have large skin cancers on their nose, or the skin cancer ate through their nose, and refer them to a facial plastic surgeon. Or some patients have seen plastic surgeons, or like someone, they might have seen you for a hair transplant. They're comfortable with you, and then they want to come back to you to do their reconstruction. But a Mohs surgeon is usually trained to do all three: the removal, to make sure it's all gone, to be the pathologist, and also do the reconstruction.
And these are done under usually like local anesthesia?
It's all done in an outpatient office under local anesthesia. So that's the beauty of Mohs surgery. It's done in an outpatient setting, local anesthesia. General anesthesia is not necessary, and we can tell the patient that they're cured of their cancer that day. They don't have to wait like a few days or a week to know that the cancer is gone. So we can do everything for them on that same day.
Yeah, and it's nice to do the repair right away and not just like have it sitting there.
Yeah, they're not sitting there for like a week with a hole in their face.
Right,
so
right.
We can kind of do it then and there. We make the patients very comfortable with local anesthesia, and we can do. It could just be in the comfort of a private practice.
And how long do these procedures usually take? I know it depends on the size of the cancer and how many times you have to go back in there.
Exactly. So it could take like an hour, or it could take the whole day. So, basically a patient comes in, we numb up the area that the skin cancer was found, we remove the cancer with a small margin of skin. The patient's waiting in the waiting room for about 40 minutes. And I give the specimen, the tissue to my my histotech in the lab. They process it. And then I look under the microscope. That process, like I said, takes about 40 minutes. And if the cancer is found if I find cancer under the microscope, I know exactly where it is. And then I go back into the room. I remove a little more tissue in that area where the skin cancer was found. And then we kind of keep repeating the cycle. So on average, I would say patients are with me for maybe 2 hours. Some times it could be 3 or 4 hours. Rarely is it longer than that.
Yeah, sometimes these longer surgeries where people are awake, it's a bit of an unusual type of procedure. I mean, I see that with the hair work that I do, but it's not the most common type of surgeries. Usually people are going under anesthesia,
sure,
and they're there for X amount of time. And my patients have lunch, during the day. Like it's kind of an odd
I tell
experience.
patients to bring food, bring something to drink, bring some reading material to keep busy, just because we don't know exactly how long they're going to be there.
Right. So then you've done the surgery, and let's say they're free of their cancer now, how do you manage like the post-operative period, like the scar management in particular? What are your tricks, especially if it's in a delicate area like on the face or the hands?
So I start talking to patients about scar management before the surgery. So, I talk to them about their restrictions after the surgery, like limiting their lifting. We talk about activities that they shouldn't do after the surgery. We talk about how to take care of their wound. I like them to keep the wound, the surgical site, clean it every day, and then apply like ointment. So keep the area moist with like Vaseline or Aquaphor. In select areas, I'll recommend an antibiotic ointment. And then, photo protection is definitely really important to keep the area, protected from the sun, whether with a bandage or with sunscreen. We also then discuss, like after the surgery, we can discuss like whether using a topical silicone cream would be helpful for them. Silicone has a lot of evidence to, for healing scars. So definitely sometimes I recommend silicone. Sometimes, we recommend lasers. Lasers can help improve scars so that the scar can look more like the surrounding skin. Sometimes, but not sometimes, most of the time we don't use any of those things. Usually, I don't usually need to use scar creams or lasers. Usually it's just, if patients are educated on what not to do afterwards, that can significantly help. But, whenever you do a surgery, there's a risk of a scar. So, it's, definitely important to give patients, educate patients about expectations. What do you tell patients, when they're going to have like a transplant or like a lip
I tell them
lift?
there's always a scar, because sometimes they ask if it's like a scarless procedure.
There's no such
and I
thing
tell
as a
them,
scarless.
Yeah, that's like not possible. You cut the tissue deep enough, there's always going to be a scar. And, I think there's a lot of factors beyond what we can control, and beyond sometimes what the patient can even control, just the way their body heals. Some have very active regrowth of their scar tissue, and that can have hypertrophic scar, and then we just have to deal with it, and it's not really any fault of their own. So that I think some of it has to do with how we counsel the patients preoperatively, and then also just react to like what we're actually seeing and how it's developing. But yeah, I mean, the question of whether or not to do laser on everyone, I think it's there's still some surgeons, I'm sure in your field as well, where they feel like everyone should just get lasered at a certain time point after the procedure, and others who feel like, let's just wait and see. I think you and I seems like both agree that probably better to just wait and see. And I find that at least actually a few other dermatology colleagues of mine, like I feel like they also agree with that general watch and wait approach. But there are some surgeons who just reflexively, 30 days after the surgery, everyone gets a laser treatment. But what I find is that when you give it time, most scars heal really well, if it's done properly. And it's just kind of a time thing. And that I feel like if you use especially a stronger laser and some ablative laser, you can set back the healing to a degree, because now there's more redness even when it wasn't necessary. So I guess that's how I view it.
I completely agree. So usually I don't recommend, laser therapy after scars, but if a patient is, if it is necessary, it's something that we could offer.
Yeah.
It's definitely something that, but the best thing is, I think, is counseling the patient, like, and practicing good, using good surgical technique when the surgeon's doing the procedure to help limit scarring.
Yeah.
But, if we needed to use something, whether it's a scar cream or a laser, it's available to us if needed. But usually I don't think it doesn't always have to be the case.
Yeah, I find that in terms of intraoperative stuff, things that we can try to limit, tension is one of the biggest things, as I'm sure, you would agree with. Trying to reduce tension on a wound that you're surgically, creating and then closing, I think that's one of the most important things. And I think that's what separates out, like good technical surgeons from ones that, maybe aren't as thoughtful about it, and where the scars are more consistently unfavorable. It's that tension management, and sometimes you're limited with what you can do, especially if you're trying to primarily close the wound instead of bringing over a flap or a graft or something like that. But at least, to the best of our ability, we need to try to limit tension.
Of course, 100% agree with you. I try to limit tension a lot by just doing extensive undermining, at least in my dermatological surgery. So, limiting tension is definitely the key intraoperatively.
Yeah, yeah, for sure. And then, yeah, I'm a big fan of Scar Gel. We have our own now, and it seems to help people quite a bit. I mean, I haven't done a controlled study on it, but as you mentioned, there's a lot of data on silicone scar gels, and also, tape as well, which is fine. It's just that on the face, for example, it's much more obvious if you're wearing a big
Yeah,
strip
of
there
course.
versus just like a matte finish scar gel that it makes it difficult to perceive, and you can put makeup over top of that. Someone needs to cover it up. So I'm a big fan for at least 3 to 6 months post-op. Most of my patients get our scar gel, but yeah, whether or not it's really required, I think
So
still.
you recommend starting 3 to 6 months after, or you
No,
using it for 3 to 6?
yeah,
Yeah.
using it for 3 to 6. We start, I pretty much have them do like a hydrogen peroxide test. Usually about 10 days, I find, after the procedure, they no longer have any fizzing if they were to like touch the area with peroxide. And then to me, that signals that there's some degree of like sealing of the wound, at least enough so that the scar gel is not like penetrating into the wound. And that's around the time when I have people start on it.
Okay. No, that makes total sense.
So yeah, I mean it's worked for the most part for us. But the thing is, like, yeah, some patients will still get like a slightly wider scar or a slightly raised scar. And again, we can't always prevent that. And at least what I've observed is that the thicker someone's skin is, like, and you can tell as you're cutting through it, the more at risk they are of this hypertrophic scar. And of course, certain ethnic backgrounds are maybe at a higher risk. But really, I find that the reason for that is not because of the ethnicity per se. It's really because of the thickness of the skin. Sure. So now I preemptively use steroid Kenalog injections right as I'm like done suturing the wound, and then that has dropped those hypertrophic scar rates a little bit.
Wow. So do you do those more for like which specific procedures?
Well, so especially for my lip procedures, that's the primary one. Yeah, just because it's center of the face, and I really want to cut down on that hypertrophic scar risk. So someone has thick skin. I can usually tell based on just certain features of their face that they just are going to have thick skin. But we confirm it during the procedure, and then right when I'm done putting the last suture in, I'll go back through, low quantities, maybe up to like, well, if it's like under the base of the nose, maybe usually about 0.3 cc's total of like Kenalog 10, and just some moderate depth into the skin, and that has I've found cut down on that risk, because if they're prone to it, you can always do the Kenalog injections after the fact. But if you can try to prevent it, then they're usually appreciative.
Of course, yeah. I mean, no one wants to walk around with a thick scar on their face.
Yeah.
So
exactly.
no, that's great. I mean, sometimes we have patients that come in for keloids. So sometimes, usually we just do Kenalog injections to help thin the scar, but sometimes their keloid is, it's pretty big, and no matter how much Kenalog you're going to inject, it's not going to thin out that scar. So sometimes we surgically remove the scar, and then we start injecting them with Kenalog at the time of the procedure. Then they come back and follow us every month, and we're just giving them, small quantities of Kenalog for several months to help minimize the risk of the keloid from coming back.
That makes sense. And then some of those patients will even need radiation.
Exactly. Sometimes we refer those patients to radiation as well.
Yeah, luckily with the central face, keloids are extremely rare. No one, I think, knows exactly why, but we see it laterally, right? Neck, ear. But like, have you ever seen a central
I've
keloid?
never seen one, not in person. I mean, usually the keloids I see are, like you said, on the ear, on the chest, on the upper arms, but I've yet to see one like in the center of your face.
Yeah, it's very unusual. Even in the literature, I remember looking this up, and again, we don't know exactly why, but that also goes for people worry about like FUE, FUT keloids. Never really seen it, and then I think the word keloid. Maybe you can explain this to people, but it gets thrown around like some people just call like any scar a keloid. And to us, we know it has a specific definition, but maybe if you want to elaborate on that, because I think a lot of people don't fully understand like what a keloid.
Yeah.
We're talking about a specific type of scar here.
So keloid scar is where the scar is going beyond the boundaries of where the trauma was. So let's say someone has a surgical excision where we cut out a skin cancer, and it was done on their chest. So in the chest, there is a little bit of a higher risk to develop a scarring, but the keloid scar is where the scar is going beyond where the incision was made, versus like a hypertrophic scar is like a thicker scar that's just along the suture line. Some patients come in to see me and they say they have like a keloid scar and it's just like a discoloration, or someone had like acne and it's a patient that, as a patient of color, and then the acne went away, but then they're left with brown spots. So that's just post-inflammatory hyperpigmentation. It's not like a keloid. So I could help patients, treat the discoloration. But yeah, I think it's super important. A lot of patients don't realize that there are different types of scars, and the treatment is different.
How do you manage the post-op like hyperpigmentation? Because usually, if it's really significant, I'll refer out to a dermatologist, because I don't feel like I have all the full knowledge set and know exactly which topical thing to use.
Yeah. So if patients, let's say, for my prior example, patients have a lot of hyperpigmentation on their face after having acne. So, there's prescription medications that we could recommend that'll help lighten those brown spots. We can recommend some over-the-counter, serums like vitamin C serum. We could recommend some prescription strength retinols. We do things in the office like medical grade facials. We have lasers in the office. So usually I try to start with topicals, but it all depends on the severity of or what the underlying problem is. Like, what was it, a surgical procedure where patients got like some post-inflammatory hyperpigmentation, or was it like patients that had acne? So, if someone had acne, then, certain medications will help their acne, but at the same time help them with the residual brown marks.
What about hydroquinone? I know that's one that's sometimes used. Are you a fan of that?
Yeah, so I use hydroquinone sometimes for patients that have like melasma, like brown patches on their skin that's hormonally related. There's other treatment options too. There's a lot of other things that we can use in addition to hydroquinone, but hydroquinone is definitely very helpful. It definitely helps lighten the brown spots. There's other things like kojic acid. There's niacinamide, to name a few. So there's a lot of different creams or topicals that we can use to help. But the number one thing is sunscreen. So if you don't wear sunscreen, you can use all the prescription or over-the-counter medications you want, but it's not going to go away. You need sun protection. So whether it's from a surgical scar, a scar from, discoloration from acne, you got to practice sun-safe behaviors.
And then for the post-operative redness that people have, just this erythema that we know is just, the usual, kind of inflammatory process as it's healing. Some people are bothered by it. I usually, again, just tell them that it's going to go away with time, and it always does. But there are some people where a year out from their procedure, there's still a little bit of that pinkness to the skin. At what point do you start to like intervene and do like a laser treatment for that? Maybe if you can talk about how like the lasers are different for that versus like if you have a white scar that you're trying to resurface, and do you like employing those types of lasers or treatments for the redness, or do you just kind of usually let it go?
So, after a scar, the area can be a little red. So I definitely, like I was saying, recommend sun protection. And I don't stress, I don't recommend usually doing a laser right away. But for the patients that are very concerned, they're very anxious, it's affecting their quality of life, we could, there are lasers that target redness. Lasers have different wavelengths. So certain lasers have a wavelength that's for a red scar, like for example, a V-beam laser. And the laser can help decrease the redness. Mm-hmm. So I usually do not recommend that right away. Usually I follow patients, and most patients the redness will go away with time, or it'll significantly lighten. But some patients, even after the redness has lightened, they're still bothered by it. So for those patients, we could recommend, for example, a V-beam laser. There's other lasers that treat redness as well. Those lasers are different than the ones that treat like a white scar. So, there's resurfacing lasers that we use that can treat the white scars, like a CO2 ablative laser. There's non-ablative lasers like a Fraxel Dual that we could use. There's a lot of different options with lasers, but I'm more conservative. I don't usually recommend those right away. It's usually the patients that are, it really bothers them. It's affecting their quality of life. So we can intervene in earlier on for those patients. But it's not, I think for most patients, the scar will fade and they end up being happy.
Yeah, and that's why for, many of these different like qualities of the scar, if it's not just like a super wide scar that has a lot of, cross hatches that I see usually as a revision case from another clinic, let's say, where it's like, okay, I'm probably going to operate on that because it's going to be hard to make that much better with, creams and lasers. Yeah. If it's not that type of situation or like a hypertrophic scar that I know I can improve with some steroid shots, I usually do like to, in the other cases, refer out to a dermatologist, because I feel like you guys are best equipped to manage the coloration of the scar, as well as like kind of fine tuning it later on if it's just about kind of blending it into the surrounding tissues, because there's again so many different lasers, and also depending on the skin type, right? You might choose one laser over another one. So you need to have all these lasers at your disposal to pick and choose. And most plastic surgeons don't have the arsenal. They might have one or two things. Same thing with the topicals. They might have one or two topicals that they know could work, and everyone just gets that. But I think the more things you have at your disposal and in your armamentarium, the better you can treat the person.
Yeah, it's definitely not like a one size fits all treatment for lasers. It depends on a patient's skin color. Like for example, like if you had a white scar on your face, the treatment for you might be different than like a African American who is a skin type 6, whose skin is very dark. If you use the wrong laser, you can disfigure someone. So it's incredibly important to see a dermatologist or a plastic surgeon who is, an expert at lasers, who is trained properly and knows which laser is appropriate for a specific patient.
That's great. And then I guess also just wanted to touch on microneedling. I'll tell you some of my thoughts. I don't do microneedling much other than for the scalp, and that's just for blood flow, as we do a PRP session, for example. But as far as microneedling for scar tissue, my observation, especially with lip lift scars, is that it's much more likely to cause atrophy of the scar, an atrophic scar, compared to like other scar management approaches. So I usually don't actually advise against it. I've seen that happen, and maybe it was the operator, but I've seen it happen in from multiple people's clinics. So I try to avoid it specifically for at least a lip lift scar. But that being said, I know that microneedling is used, and there's some data to support it for scar management. So just wanted to get your thoughts on that.
Yeah, so we don't always use lasers, so sometimes we do microneedling as well. So microneedling, they have microneedling pens where they're like fine needles that we're kind of going over scar tissue, or we do it over the full face of patients. So it's common for patients that have acne scars. So one thing you can do is do microneedling over the acne scar or the full face, and that does help stimulate collagen. We can combine it with PRP to get some growth factors in there as well. I've seen patients with good results, but it always depends on the type of scar. So it depends on the type of scar that you're treating. If the scar is like, superficial scarring from acne, I've seen good results. But if it's like more of a deeper scar, I haven't seen as good results. So I think there is a role for microneedling as for different types of scars, but depends on what exactly we're treating.
Most challenging part of starting your practice. I know that it's been, well, you've been out of training for how many years now?
I finished fellowship in 2016, so it's been
Eight
it'll be
years.
8 years. Yeah, so it's been eight
Yeah.
years. So I actually worked at a few different private practices for about 7 years. My Before I finished fellowship, or while I was a fellow, I spoke to my mentors and I asked them, what would you recommend? Would you recommend, like, I was always interested in opening up my own practice, and I asked them, would you recommend I open up right away? And they all told me the same thing, that they would advise against that. They said to, gain experience working in other practices, see what works and what doesn't work at these offices. So I ended up working at other practices for about 7 years. And, around the time of COVID, I was like, okay, it's time for me to start looking for a place. So a month before COVID started, or maybe 2 months, I started looking for spaces, and that's when everything shut down. So for a year and a few months into COVID, once things started to open up again, I started to look around for spaces, and I was close to signing a couple of different leases. I, found spaces I liked. They were in good locations. I liked the building, and then I got lawyers to review the lease. And then a couple of times, the last second, the landlord changed the lease, and
Yeah.
I already spent all this money on a lawyer, and it was just, I eventually found the right space where it worked out, but finding the right space was a limiting factor in the beginning. But after that, the next most difficult thing for me was finding staff that had the same vision as me, that had the same passion. It did take some time to find the right team members, but I'm very thankful that I found them, and now things have a good flow and are working well in my office. So definitely the location was hard to find, or the right
Yeah.
space, and then finding the right team to
Yeah.
run to make everything mesh.
So I don't watch a whole lot of YouTube. I mean, I try, but I don't probably watch it enough, because I'm on the platform. Like we post a lot to the platform, so it's good to be part of the platform as much as possible. So I do try to watch, but there's this one channel that I watch very frequently, and that's the Colin and Samir show, the Colin Samir channel. They're two guys, and they have a great channel that helps support like content creators, like basically YouTuber. It's like it's YouTube for YouTubers. It gets into a lot of the nitty gritty stuff about how people, not just like what the best content is to post, and how to do that, but really getting into like the businessy side of things, because nowadays a lot of creators are starting their own businesses, or at a minimum, it's kind of like you're running your own mini business. This is unique in that, I have a practice to run, and then I have a YouTube channel to run, and they're interconnected, but they're kind of
Yeah,
separate
I don't know how you do it,
businesses.
honestly.
It's like, well, like being here on a Sunday, that's how we do it. Just a lot of work, but it's all good. It's everything feeds on each other, and it's, on itself. It's all one kind of big thing, but yet it's split up in a way, right? So something that comes out of the Colin and Samir show pretty often is that they'll have like, a creator on, and they'll ask them like, what's the arrangement of your business, and then they go through different like elements of it. But one thing I think it's always interesting to hear is like the composition, like the team composition. For some creators, it's just like one person, and that one person is doing the filming, the editing, the posting. Like it's just one man show. But that's becoming exceedingly more and more rare, because you need help,
Sure.
and especially if you're going to grow and whatever. So I feel like as I've been watching that for, I don't know, I've been watching them for at least a year and a half or 2 years. I always thought that, once I had like my own little podcast thing going, especially having other doctors on who have private practices, it would be interesting to talk about some of those elements. So one question is, again, like the composition of your team, because I agree. I mean, finding people with the right personalities that complement you, that can take good care of your patients. I mean, that's a big part of it. But I think it would be, and it's something that no one really even talks about, especially for like medical practices, like who's on your team, and everyone has like a slightly different composition. So I'm just curious, like who makes up your team, at least at this time, or the types of roles. You don't have to give me
Yeah,
names.
so right now I have like a lead receptionist who also is kind of like an office manager.
Hmm.
So she's, she makes sure I accept a couple of insurances, so health insurances. So she makes sure that everything is we're in network with their insurance, and kind of sets everything up. She helps give them the initial paperwork to see, learn about the patient, like any medical, what their medical history is. I have a couple of medical assistants that help me with patients, whether it's with just regular medical dermatology, whether it's with surgical dermatology, Mohs surgery, or any cosmetic procedures. So, I have a few, I have, two medical assistants. I have a Mohs technician who comes in that helps me when we're doing Mohs. We have a lab in the office, and she oversees the lab. She makes sure that we're fully stocked with everything. She processes the skin when I give it to her when we're doing Mohs. And I have a biller that helps, for the patients that we see through insurance to, make sure we're submitting the claims to the insurance properly. We're getting paid from the insurance. And currently, I also have my wife helps also, so she's also part. She acts as like a helps us being the office manager at times, making sure everything is running smoothly. She checks in with the patients we have. I'm sorry, with the staff. We have regular office meetings to get everyone's feedback. So
Yeah.
like a small team. So,
Right.
it's, we just opened about 9 months ago. So, we're kind of slowly expanding.
Yeah. Well, congratulations.
Thank you so
It's
much. I hope
it's a big
that my
move.
practice could be anywhere like half as good as yours.
No,
So
no,
this is like a beautiful practice. You guys should, I don't know if everyone has seen your practice, but it's beautiful.
thank you so much. Well, we did put out a video about at least the new office space. We have that out on the channel from like maybe a few weeks ago. So we tried to walk people through like the physical space, but I still think people don't get to like meet every team member, and it does take a village for sure. Like I think of it as like kind of front end and back end, help, just like you, because we do procedures, so you need people to physically help you with surgery. So I have like hair technicians, I have a PA, I've got two receptionists, a patient coordinator, and then my wife also helps me,
Yeah.
and she helps with some like just the administrative stuff, and it's pretty common actually for many private practices to have like a spouse or a family member. I have a buddy in California, and his dad is like the chief administrator for his whole
Really?
practice, and he has like now a few other physicians working in the practice and a pretty big team. Yeah, I mean, it's super helpful. I think some of it stems from just like, just having someone you trust kind of
Of
oversee things
course.
on the management side, but also like the finances. I find sometimes they'll intersect, especially on like the accounting side. When we work with our accountants, the personal finances and the business finances are not like super separate. I mean, there's some interplay there. So like if you have just someone you took on as a manager, I mean, they'd probably be privy to all that information, which is a little bit
It can be
intrusive. It
nerve-wracking.
could be
Yeah.
nerve-wracking, a little intrusive, and So I think
To
it's
really
helpful.
trust the person. Yeah.
Yeah. So having them be like a family member, I think is helpful for sure. Yeah. So that's on that front. And then in terms of running a practice, I mean, there's lots of headaches. I mean, it's great when
Yeah.
things are flowing and everything is and everyone's happy, but there's surely, a lot of my time goes towards just making sure that things run smoothly. Um, what do you find to be some of like the challenges of running the practice?
So one of my challenges is definitely dealing with health insurance. So we accept couple of major insurance plans, and a lot of times they make it very difficult to treat patients. Like we have to get authorization for like a specific medication, or we have to get authorization to do a procedure. So frequently it's might be denied, and then we have to appeal it with a letter. Usually it ends up working out, but it definitely takes up a lot of your time, and sometimes they still refuse it. So you know, the patient has to get involved as well. It's definitely a challenge. So, one challenge is definitely dealing with health insurance, and they make it very confusing. So patients don't always know what their benefits are, if they have a deductible, but that's definitely one challenge, has been dealing with insurance and,
Hmm.
and billing.
And that reflects on you and your practice. I mean, you could have done the most amazing surgery, cured someone of their skin cancer, and let's say the wound healed perfectly and everything is great. But then they're hit with a bill because the insurance said they were going to cover something and didn't
Right.
cover it. And now I would imagine there are some cases where someone might be upset, like because you need your expenses covered, you need to get paid, and now it's like, well, now it's falling on the patient, and maybe they didn't anticipate
Right.
some of those
Yeah,
fees.
so it's important to go over the patient's benefits with them prior to the procedure. I have one of my staff members, review their benefits and, make sure they understand if they have a deductible or not. Like, they might be responsible for some of the bill, because it might, if the procedure goes to the deductible, that means that you're responsible for the service up until a certain point. Like you might have like a $2,000 deductible. So your insurance won't cover anything until the $2,000 deductible is met. So it's important for patients to, in that situation, for them to know in advance. It's kind of crazy. A lot of patients have no idea what their benefits are. Maybe they got their insurance from an employer, but it's very confusing even for me. It's the doctor. So I definitely very grateful to have my staff that looks up at this stuff before, and they review it with the patient so that they know that if they might have a balance or not afterwards. So this way it's all known prior to the procedure. um, yeah, healthcare is with insurance is very challenging. It's not an easy road.
Yeah, that's probably one of the least fun
It's the
parts
least fun
of
part.
the job.
Seeing the patients is usually is the most enjoyable part.
Yeah.
So how trying to help someone, overcome something like skin cancer or regain having a patient, treat their acne, restore their confidence. That's easy. Maybe not easy, but that's the fun part. For you, what's the biggest challenge of running your practice?
Well, at this point, I have these like three buckets. I've got the practice, there's YouTube, and now there's the Feel Confident brand. And it's really three different businesses. Again, all interconnected, but all separate. I mean, there was a time last year when some stuff was combined together, and then we separated it out so that everything is nice and clean as far as like accounting goes and all that. And really trying to juggle those because each one requires like a lot of time. Anything that you want to see grow, you've got to put in the time, the money, all of that. So trying to juggle between those is difficult, and that's probably the most challenging right now. Like if I'm just looking at the practice itself, um, there luckily on the marketing side, because we have the YouTube and we have like great SEO with my website team and all of that. I mean, there's a pretty good steady flow of patients, which is nice. And as we put out more results and people are like, oh, this is great. And, it kind of comes full circle. If they just saw something on YouTube and, they came in for surgery and they got some, I don't know, horrible result or something, then the system, couldn't continue. But luckily, people generally do very well and they're happy and they tell others and it just keeps going. So that's good, but that also, I mean, you have to kind of track that, throughout time, and there's overall good flow, but like there are certain months when things, go up, go down, and um, I'm always like looking at that. I mean, you have to know like what's happening, with that. Um, I would say like probably the most challenging thing is just keeping like personnel like happy in ways, because there's different ways to keep people happy. It's a balance of keeping them happy but keeping them highly productive, and sometimes those two work hand in hand, and sometimes they work against each other. I mean, like I think I'm a nice boss, but I can come down hard on my people if like things aren't, especially on the YouTube side, on the brand side. I think I'm a little bit more easygoing, but on the practice side, when we're actually like taking care of real patients and there's real risks and all this stuff, like I really want to make sure that things are done properly, and if any small thing is out of place, whether it's during a procedure or just like I notice an email was sent, incorrectly or something like that, I go and I address it with the
Sure.
individual. But also staff can sometimes have like they have different asks. Sometimes it's a vacation that maybe they have a family member visiting from another country and they're like, oh, like, can I take off in 3 weeks? But we have surgeries. Now it's like, well, it would have been nice if you gave me more time, or people asking for raises. And we try to keep people as happy as possible, but there comes a point where it's like, well, there's only so much I can do,
Yeah, no,
and that's a
I have
challenge.
the same issue with my practice. We've only, like I said, we only recently opened up 9 months ago, but yeah, staff members asking for vacation last minute, or staff members not following up with certain patient requests. Just addressing some of these issues with the staff, and just trying to make sure that certain things don't happen again. But definitely keeping everyone happy, is a challenge.
Yeah. Yeah. Even like organizing activities outside of work, for people. Like I thought at one point that if we did like monthly get-togethers and let's go to the movies and let's go like do mini golf and all these things, that everyone would just like love being at this place and like, yeah. But what I learned was that most people, they don't want to meet up and hang out all together multiple times a year throughout, every month. Like it was just too frequent. So now we try to do maybe like a quarterly thing. And even then, like we don't have like some massive team, but sometimes it's like a quarter of the people, or we've had times when half the people only show up, You're like, where's everyone else? So like, I don't know. Sometimes I'm like, shouldn't people make more effort to just like hang out outside of it? But then again, they're here, often. So they may just want to spend time with their families,
Sure.
and I respect that. So now so we've calibrated that a bit over the years as well.
No, it's challenging, like balancing work with your personal life. Like I have a couple of little kids. I have a 2-year-old and a 1-year-old. It's really hard for me to try to balance everything with the practice and being with my kids. So it's really I'm becoming better at it, but it's not easy to try to balance your personal life with your work life.
Yeah, for sure. Yeah, yeah. I mean, and when I was talking about those buckets, that's just like work, the work life, and then you're right, there's home, and then, balancing home with work also, really difficult. And then the other thing with staff is like the whole like remote thing, because after COVID, it seemed like people got really used to remote work, and I feel like many of my staff members they really appreciate having at least some time to spend remote during the week. Now we do surgery, so it's like we can't do that remotely.
Right.
So it's like, how do you give them time and yet take good care of patients and do enough surgeries to pay the bills and all of those elements. Everything has to work together. So for me, for example, having two receptionists, just one example, is helpful to give each one of them some remote time. So like they kind of split the week. So one of them might be in 3 days, the other one's in 2 days, and they flip flop. And then when they're at home, they're still doing stuff. I mean, I see them writing emails, and they're still doing some work, of course. But it's different. They're not interacting with patients face to
Right.
face, but they'll make phone calls, they'll do emails. There's usually enough for them to do, and so they feel like they don't have to come in every day. And because our days start early, the person coming in is usually here by like 6:45, and if they're traveling in from the suburbs or from a different borough of the city, like that can be difficult, and I respect that. So it's always just like a balance of.
No, that's really good though that you're able to allow them to do some remote, work for your receptionists at least. Like for me, when I was interviewing interviewing staff for the positions, some people only wanted to work remotely, and I'm like, I don't think there's no way that would work here. You have to, this is more of a position like in a doctor's office where you have to come in and physically be there.
Yeah.
So like, so, remote has become a big thing since COVID, but that's awesome that you're able to balance your receptionists, like where they could, every other week switch off, like who's more, work part of the time they're remote every week, and they can kind of switch off every other week where someone's 3 days versus 2 days.
And I've also found that redundancy helps, for different reasons. One is that, look, people can get sick, they can potentially, quit. So
Right.
it's helpful to have some sense of redundancy within the system, within, amongst the staff, and so that has been good. And it's not always possible. You take someone like having a PA. I mean, there's some added expense to that type of position, and so it's not always easy to just like, oh well, I'll just have two PAs, like maybe one day, but I mean you need to be able to support that the second type of person. So but still having some degree of redundancy, I've found has been really helpful, especially like again, you have like a case scheduled. Like the last thing you want is to have to change
Right.
that case to a different day, or to bother the patient with the rescheduling, if you can avoid it. But yeah.
No, that's huge. I mean, like you said, what if someone, your main medical assistant or hair tech got, called out sick and you didn't have a backup or something? Then you'd be in a dilemma. So it's definitely important to have like extra help.
Yeah. And the staff, I mean, it's such a huge part of running the practice, right? Like if they're great and they can, like, you can offload some of the stressors, then that's awesome. If they're not great and they're causing like more headaches and more stress for us, that's not good, and that could potentially spill over into the way we execute our work.
Yeah, no, patients can tell. I think in other practices that I've worked at in the past, there was a lot of drama going on, and patients could tell that something wasn't right, and they could sense tension. So that's why it's so important, I think, to pick the right team members to work to be with you in your office.
Yeah, for sure. Lastly, what would you say would be like one of the most like rewarding parts of the job?
I would say probably definitely the relationships that I developed with patients over the years. So, I've treated, thousands of patients over the past 10 years, and, from curing patients of skin cancer to treating patients that have severe acne, and, helping them overcome that and restore their confidence. We were able to have like a great impact on patients' lives. I've seen patients that, were suffering from depression because of their acne, and then we were able to, cure them, and that we were able to overcome that acne, and now their confidence is soaring. Patients that were diagnosed with a skin cancer and they were devastated, and just treating them for that skin cancer, and now they going over how to live their daily life, like how to go about with sun protection and everything, so that patients can now just go about living their lives as to the best of their abilities. I would say that my favorite part of everything is definitely the relationships that I develop with patients. I've definitely seen patients that now they referred me their mom, their dad, their sibling, their best friend. So those bonds that I've made with patients over the years.
Right. That's awesome. Yeah, many patients come to me for like a one and done type of situation. I like to think that, especially with hair loss, it's something that they still need to maintain some degree of medical therapy. So they're usually not completely gone, but there are plenty of times where it's sort of like I see them for
Yeah.
like a day, do the surgery, and then there's follow up. But then more or less they're sort of gone.
Yeah,
But it is
some
cool.
patients I see it's a one and done, but I do have, other patients that I've been seeing for like a decade that have followed me around from these different offices and now to my own office. So, definitely, makes, puts everything in perspective and makes you, it's a very rewarding feeling.
Awesome. Thank you so much for joining me today.
Thanks for having me.
Yeah,
This was great.
Yeah, we're in the same city, so
Yes,
we can
yes.
do this again sometime.
Yeah. Thanks so much, Gary.